morning, everyone. Thank you, Dr. Arbona. Oh, I have it. Yeah, thank you. I don't know if he snuck out, but his lecture was very interesting. What I took from that is I need more equipment in my ER bag for my Baker Act patients in light of our ketamine shortage. So it was cool to see that I can get some of those things and what those things could do. But I'm Dr. Walker. See a lot of familiar faces here. I'm the EMS Medical Director for Osceola County, St. Cloud Fire Rescue, and also Kissimmee Fire Department. I'm also here with one of my residents, Dr. Yasa there. I'm the Associate Professor for Emergency Medicine at UCF HCA Greater Orlando Emergency Medicine Program, and we have a couple of faculty here that are going to be coming to you guys as well. So thank you, Dr. Banerjee, for the invitation. Appreciate a chance to come back and enjoy this wonderful symposium with you all. So today, I was invited to talk about the difficult airway. And I don't have any disclosures, but the following content you're about to see may present views that will undoubtedly save a patient's life, and for some of us, that may be disturbing. So we'll get right into it.
911, what's your emergency? Excuse me? Can you please give a description? Yeah, I think hypoxia, hypotension, and acidosis. They're all here. Okay, calm down. We'll send someone your way. What's your location? 101 Reckless Intubation Way. Oh no. Dispatch all units. Hurry! They got it.
We are coming to you live from News Channel 8, where we're about to be on the scene with what is another reported sighting of the Hops Killers. That's right, the Hops Killers. We're on our way now to 101 Reckless Intubation Way, where someone called in and said they had just seen the Hops Killers around. I'm told that the victim is 63. She has a glucose of 536. She's very hypotensive at 60 over 40, heart rate of 114, and a respiratory rate of 34. Again, that's the victim. If you see her, please call in and let us know. We're currently searching for the Hops Killer headed to Reckless Intubation Way. We also have been told since covering this story that we think there are some people acting in cahoots now with the Hop Killers. I think they describe themselves as emergency residents and EMS medics. We're told that they're ones that fall asleep during didactics and medics who are not completing their online target solutions training. Again, if you see them, beware. Let us know. This is Ayanna Walker, over and out. Banerjee, take it away. You guys know I can't just, for those of you who know me, I have to be a little silly, and he just told me to get up here and give you 20 minutes of a lecture, and that just was too much for me. I couldn't follow instructions. But we're going to dive right into it, and we're talking about the Hops Killers in the context of the new RSI. So my medics always ask me, when are we getting RSI? Well, here is our RSI, resuscitation sequence intubation, or more widely known as resuscitate before intubate. So that's what we're going to spend the next 15 minutes discussing today. So our objectives, we're going to define what these Hops Killers are. We're going to discuss a few clinical scenarios in which they may present. And then finally, I want to leave you with some strategies to help you when you are out there and you encounter these Hops Killers. How can we, dare I say, prevent or at least mitigate some of these bad outcomes? So simply put, I want you to go from this whenever you're intubating a patient that has a Hops Killer to this. All right, so, and that cup has some significance, so we'll tell you about that a little later in the lecture. So a couple of you who've never heard of the Hops Killers or who never heard of this concept, resuscitate before intubate, you may be asking yourself, why is this a topic of discussion? Why are we discussing this? Why are we thinking about this? Isn't the patient sick? Don't I need to hurry and put an ET tube in? Aren't they dying? Like, shouldn't we, the faster we intubate, isn't that, better? And it's kind of like Dr. Sobowale was saying, we're so used to the ABC that we're changing things up, and now are there circumstances where it should be CAB? So this is what the overall concept of resuscitating before intubating is, getting us to stop and think and actually, optimize the patient's status so that we can help prevent or mitigate these outcomes. And so why are we talking about it when we talk about bad outcomes? So actually 4 to 28% of all of our intubations end in complications. Aspiration can be a complication, right? But we're talking about more severe things like hypotension, leading to, or hypoxia or acidosis, but all those things leading to cardiac arrest. So what good is it if the patient is peri-arrest, not dead yet, they're actively dying, we hurry and put this ET tube in, and then we cause them to actually die? You know, what's the point of that? So this whole discussion that we're gonna have today is about how can we help prevent those bad outcomes. Okay. So let's define HOPS killers for those of you who haven't heard of these before. HOPS stands for H, hypotension, O, oxygenation, and the P is pH, like when you're talking about a pH of something, that's the acidosis. So those are the 3 killers you need to be on the lookout for prior to intubating a patient. So in what clinical scenarios will we see these? Well, there's a ton, but a few that come to mind specifically with intubations that I've been involved in are the pregnant patient or postpartum patient, peripartum cardiomyopathy. These are very sad cases where essentially you're dealing with a patient that is in CHF or cardiogenic shock, and they may be pregnant or they may still be, they may be postpartum up to 6 weeks. So, you know, be careful of those patients. They can present just with some mild shortness of breath and just some leg edema, you know, what you typically expect a pregnant woman to have, all the way up to cardiogenic shock. So those things could cause hypotension, it could cause hypoxia, and that can lead to acidosis. So that type of patient may have all 3 HOPS killers, and that's someone you want to say, let me pause before intubating and figure out how I can help mitigate this bad outcome. The patient that we see all the time here, unfortunately, sepsis. Sepsis is a big thing now, and specifically septic shock are one of those patients that when you have that clinical scenario, you want to stop and think before you just go ahead and put that ET tube in. Sepsis can be from anything, pneumonia, necrotizing fasciitis, infected kidney stone. I mean, any kind of infection out there you can think of can lead to sepsis and then septic shock. And these patients need to be aggressively resuscitated before we intubate these patients. So sugar. So the diabetic, right, or the undiagnosed diabetic, and they present to you in DKA. A lot of these patients have an infection that precipitates this, but you definitely want to think about DKA because that's a very different intubating strategy than we're normally used to. So don't rush in to intubate a DKA patient. You need to stop and think, and I'm gonna give you some strategies here today that'll help us with that type of patient. Your trauma patient, like Dr. Sobowale talked about, the patient that he presented, you want to resuscitate that patient first. So before we're thinking about airway, he said, do what? C, circulation first, like help with that massive bleeding. And then just your typical, you know, CHF patient that you run on every single day may present with signs of fluid overload, like the lungs have some crackles in it, or maybe cardiac wheezing, and then some leg edema. Those patients we need to stop and think about as well because they could be hypoxic, and we need to talk about ways that we can help prevent the complication of cardiac arrest for them. And then finally, pulmonary embolism. Those are pretty scary patients to intubate, and you know they could be hypoxic as well. And we just need to stop and think in all these scenarios. And there's plenty more out there, but basically any patient who could become or is hypotensive, who is hypoxic or has acidosis, these are the patients that we're talking about that we could actually kill with our ET tube. So let's jump right into the strategies. For hypotension, I'm just gonna list the strategies right now, and then we'll pick a couple that we're gonna kind of go in depth with. So hypotension, IO access for sure. They need IV fluids, and in our trauma patients, like we talked about, blood. Push dose pressors are a pretty new thing here, vasopressor drips, and then we're gonna talk about your dosage requirements or adjustments as well. Hypoxia, pre-oxygenation. I can't stress enough how we look at intubation as a procedure. We need to look at pre-oxygenation as a procedure. It needs a whole timeout. There's a lot of equipment that we're using, and a lot of times in the case of the kids that Dr. Plumley was speaking of, we don't even need to get to intubation if we do really good pre-oxygenation. And I'm sure Air Care, if they're here, can vouch for that as well. If we just do really good pre-oxygenation, there's no need to even intubate kids. Delayed sequence intubation, and then apneic oxygenation as well. And finally, moving on to acidosis, things you can do here. First of all, we gotta identify. So that's where you guys come in the pre-hospital arena, being able to identify these patients that could be acidotic. Mostly I'm talking about the DKA patients. So you have your BGLs that you guys are so good at getting. You see that says high. We have our end tidal, which we're all good at getting now too. And you see that low. High glucose, low end tidal is DKA until proven otherwise. I know Osceola County, we just got that protocol that helps us define and identify DKA. So if you don't have that in your protocol yet, or it's not something that you're thinking of, anytime you have high glucose, low end tidal, DKA until proven otherwise. And just a word on that. A couple of weeks ago, we actually had a patient safety conference, morbidity and mortality. We had a patient that came in, 1 year old. Mom was like, oh, she's had a mild URI for a couple of days. I triaged her, and she looked well, but mom was like, I brought her in because her breathing has just been a little bit off. Well, at that time, breathing looked great, child looked great, no fever, nothing. Vital signs and everything normal except a little bit tachypnic. A little while into the emergency department, after getting RSV, flu, chest x-ray, all those things, everything's coming back negative, and mom comes and gets us and says, she's doing that breathing I'm telling you about. And she'll have this like period of apnea. And so my resident grabs me and she's like getting RT and she's like, I think we need to intubate this kid. So we're going in, and long story short, I think the Moores actually came and transported that patient. They ended up getting a blood glucose level on this 1 year old. It read high, greater than 500. We ended up seeing that basically she was undiagnosed diabetic, presented to the emergency department for the first time in DKA. Had we intubated her, we would have probably killed that infant because we didn't know what we were treating. So identifying acidosis is way more important for you guys than the treatment that we will do in the emergency department. Finally, IV fluids, and then a ventilation strategy called VAPOX. So the ones highlighted in pink here are the ones I'm going to go over briefly. So talking about IO access, for Polk County, you guys use humeral or tibial? Both? Okay. All right, so I just want to direct your attention to, when you have a chance, Teleflex is the company that makes the IO. Go onto their website. They have a really cool video of some cadaver labs that I've been able to be involved in, where they dissect all the way down to the subclavian artery and vein, and they show the humeral IO, and it literally, the fluid gets into the heart in less than 3 seconds. So I'm talking about, that's the same amount of time, if not faster, than the central line that we use in the emergency department in the trauma bay when we need to give blood to a trauma patient very fast. So skip the peripheral, skip the tibial when we're talking about these peri-arrest patients with these HOPS killers, and go straight for that humeral IO. Then we have here that cocktail I showed you earlier. I think I coined the half double is what I call it. It's just a reminder that in these shock patients, you need to use half the amount of sedative that you normally use because they're already hypotensive, and some of the medications that we're giving can make them even further hypotensive. Also, that's the point for ketamine. I know we're on a shortage now, so I'm trying to keep that in the bag and not tell you guys too much about ketamine so we can keep some stock. But ketamine is the drug of choice when you're dealing with these patients with HOPS killers, particularly hypotensive patients, because it doesn't affect the blood pressure as much as something like etomidate would. And then double the paralytic because they're in a shock state, and so the time of onset is going to be greater in these patients in a shock state, so you need to increase your paralytic, which I don't think anyone here is doing RSI except for probably air care, but you want to double the paralytic on that. For hypotension, the other thing is push dose pressors. So I know a couple of us have this in our protocol. The overall, the overall concept is that you want 9 cc's of normal saline and 1 cc of that cardiac epi that's in your code card. You can make it however you prefer. So we have some that will use the epi vial and draw up the 9 cc's there, which I would say is a much safer approach so that you don't have a non-labeled vial of medication there. Or you can use the 10 cc normal saline syringe, take out a cc, and you draw up that 1 to 10,000 epi there. The dose you're gonna give is 1 to 2 cc's, and you're gonna do that every 5 to 10 minutes while you're resuscitating this patient in preparation for intubation. So we have not gotten to intubation yet. We're still just aggressively resuscitating this patient. I like this because all we're trying to do is play with numbers. You just want that number to get high enough to where you can intubate the patient, and they're not gonna go into cardiac arrest because their blood pressure was already low to begin with. So that's something my residents really love to see. Then moving on to hypoxia, which I would say this pre-oxygenation, like I said, just stressing the importance of it. the dreaded curve that we don't want to see again. But the only thing I'm going to tell you about this curve is I want you to have it in your mind when you're intubating these patients who are hypoxic. So when we do pre-oxygenation in Osceola County, we stress that we need to do about 3 minutes of pre-oxygenation. Reason being, think about it like you're trying to increase the reserves as much as possible, right? Like you want to get all this oxygen in to your lungs and you want to have a nice reserve so that if you're having to take a little while intubating, maybe you're like me, who my residents take all my intubations and I don't get to do one but every 3 years. I want a lot of time to intubate. The only way you can get a lot of time to intubate now that has been shown in studies is to get that oxygen for as high as you can for as long as you can. So that's that curve that you see at the top where he's just kind of coasting along. That's 90% O2 to 100% O2. So if you have pre-oxygenated and they're staying in that range, you're gonna have some time to intubate. Once that patient gets to 90%, that's where that red arrow is, they're gonna drop precipitously. So I've seen patients go from 90% to 60% in literally 2 or 3 seconds. That's not enough time for even the best person in here to intubate. So what do? You do great pre-oxygenation. I'll give you some techniques in a second, but you gotta keep them above 90%. Also, if you're intubating and they get to 90%, you need to abort that procedure. I know that's something that's not widely taught. It's absolutely necessary because, again, you drop so fast off that cliff. Once they're at 60, there's not much you can do to bring them back up. They're gonna go into cardiac arrest pretty soon. So the techniques that you can use to keep them as high as they can for as long as they can, and for our medics, I know some of you guys are only intubating once a year. You need as much time as possible to intubate. So take this time to pre-oxygenate first. So how do we do it? We're gonna put the nasal cannula on, we're gonna turn it all the way up, all the way up. So I know it says 15 liters on your flow meter. It actually goes to 40, 50, sometimes even 60. And that increases our FiO2. So you'll actually hear it. If you keep turning it past where you think is the highest level, it's gonna go up even more. So get that on them immediately when you think that you're gonna have to intubate. Go ahead and start this procedure. Additionally, if they are spontaneously breathing, you can put the non-rebreather on top of that and do the same thing. Turn it all the way up. We call that the flush flow rate when we turn it all the way past what we think it should go. So spontaneously breathing, and I come in and I see a septic patient and I'm thinking, I think we're gonna have to intubate them. I'm not rushing to intubate them, but I'm rushing to start this pre-oxygenation procedure so I can get them as high up as I can for as long as I can. If they're not spontaneously breathing, and we've had some concerns in our department with GCS less than 8 and patients who aren't spontaneously breathing, sometimes they're bringing them in with non-rebreathers. That's an absolute no-no. These patients need you to breathe for them. So if you have them on end-tidal, which you should, and you see that their end-tidal is rising, they're not ventilating well, or their GCS is less than 8, those patients need active airway assistance. And we call active airway assistance a bag valve mask and greater, okay? So no non-rebreathers and nasal cannulas in these patients who aren't spontaneously breathing. So you have to pre-oxygenate them with the BVM. And I would ask you to, ask your medical directors and your chiefs and those who are dealing with equipment to make sure you guys have a PEEP valve. So we had an intern that was intubating the other day, and the O2 just would not come up. We were doing our pre-oxygenation, and we're staying at 92, and he's an intern. He doesn't want me to take his procedure, so he's like, Dr. Walker, I'm gonna pre-oxygenate for a long time because I need a long time to intubate. No problem, we got all day, stay here. So his oxygen wasn't coming up, so what he did is put that PEEP valve on. And I think about 2 years ago when Dr. Banerjee did this symposium, there was a physician out of the Carolinas that showed this video, and you can YouTube it, just YouTube PEEP valve and like cadaver lab. And what you see is that the lungs, when you don't have a PEEP valve on, the lungs will expand and then they deflate all the way. And they expand and they deflate all the way. When you put that PEEP valve on, they expand and they deflate some. And they expand more and they deflate some. And they expand more and they deflate some to the point where you're not even deflating. And what that does is recruits all of those alveoli so that your O2 can be higher. So you see this in real time. Put that PEEP valve on, go ahead and bag valve mask them, and the O2 will increase dramatically. So if you don't have that, definitely go back to your counties and let them know about that. Finally, BiPAP is your friend. You can use it as pre-oxygenation. We use it all the time in the emergency department when we know we're about to intubate a patient. If they're spontaneously breathing, again, they have to be awake and alert for that. And then a little bit of a new thing is we've started pre-oxygenating patients and intubating patients with the head of the bed elevated. And just from a gravity standpoint, you can kind of see how they can gather more oxygen that way. There's a study that had about 66 patients, and they used BiPAP. They were obese patients, so BMI greater than 45. They used BiPAP to pre-oxygenate these patients. The patients who did not have BiPAP, they just had non-rebreather, they desaturated faster. So they started at about 93, and they went to 86% during intubation, whereas those with BiPAP were at 95%, and they only desaturated to about 91 to 92%. So again, why this is important is because you need as much time as you can to intubate these patients. Intubation is not that easy, it takes some time, and so the higher you get them, they'll stay in that 90 to 100% range as long as you possibly can if you're pre-oxygenated appropriately. Delayed sequence intubation I won't talk about much, but I just want to say that when you have a patient who is combative because of a head injury or they're hypoxic because of a head injury, those are patients who need to be pre-oxygenated, but are they going to let you put a mask on them? Probably not. So in this case, what we do is actually give them a sedative in anticipation for intubation. So all these patients, we know we're going to eventually intubate them, but we need to get that O2 high, right? Like, I'm not going to intubate a patient with the 89% oxygen. I want them 95, I want them 96. How can I do that when they're fighting me? We do what's called delayed sequence intubation, where we'll give some ketamine, give some etomidate first, and then we're going to intubate them. And that allows us to get that oxygen as high up as we can. Acidosis, the important thing, again, what we talked about for you guys is to identify it. If you need any help with end-tidal, there's a ton of target solutions, and also just on YouTube about how to identify acidosis. But long story short, in your sepsis protocols, it talks about a low end-tidal. Same thing for DKA, you're gonna have that low end-tidal. Those are all signs of metabolic acidosis, okay? It can be from shock, it can be from DKA, there's a number of reasons, but you need to identify it first. And then once we identify that they have DKA, or any acidosis for that matter, but why I said DKA has a very specific strategy. There's something that is not widely used at all. It's in the emergency medicine literature some, and it's called VAPOX. It's a ventilation strategy for DKA patients. So what's the whole deal with DKA patients? Why are they so hard to intubate? First off, all your DKA patients are coming in with respiratory rates of 35, 45. When we typically set our ventilator after intubating, what number are we typically setting the respiratory rate at? If no one answers, we're taking away all vents from all of the EMS counties here. What do you guys typically set your respiratory rate at on your vent? 10 to 12, yeah, exactly. So if we're setting the rate at 10 to 12, but we're intubating someone who is trying to compensate by breathing 35 to 45, what's gonna happen? We put them on that 10 to 12 rate, they're breathing slower, the acid is not being able to breathe off, acid is building up. What happens when you get worsening acidosis? That heart rate's going down, and what happens when you have a 0 heart rate? The patient is dead, you're in cardiac arrest. So that's the big problem with DKA is if you don't know that you're intubating a DKA patient first and you don't change vent settings and you don't get the most experienced person to intubate the fastest or you don't implement things like VAPOX, then you'll get a patient that codes on you very fast because that acidosis is building up. So when they're apneic, you give them those medications and they stop breathing, the person with the most experience needs to intubate them so they can do it the fastest. And you can use a strategy called VAPOX, which is going to allow them to continue to get breaths to breathe off some of that acid while you're intubating them. So quickly, what VAPOX is doing is during that period where you give the medications, so etomidate, and then now we're going to give our rock or our sucks, there is some time period that you have to wait in there, right? Like rock doesn't kick in until what, about 90 seconds or so? That's too long for a DKA patient to go without breathing that acid. So what the VAPOX does is you can use this with a BiPAP machine or a ventilator, some BiPAP machines, but all ventilators. It's going to continue to deliver breaths even while you're about to intubate. So you have that machine on, you set it, for the respiratory rate that you want, which in this case we do like 6 to 8. You can even add some PEEP like we talked about, increase that FiO2 to 100%. We're gonna give a flow rate that's nice and steady, delivering that breath over a couple of seconds. And basically, while you're waiting for your meds to work, that patient is still actively breathing off that acid. Now you're ready to intubate really fast, and now you're ready to set your ventilator at the rate that they were breathing at. So that's just a quick overview of VAPOX, but definitely you can take time to research that and learn more about that. So I'll leave you with this. Airway is probably the most life or death procedure that we do, and we need to, have respect for it and take it for that. And so just like we do timeouts for surgeries and procedures, we need to do a timeout every time we're about to take a patient's airway, especially if they're in peri-arrest and they're not already dead yet. When we're talking about patients in cardiac arrest, a lot of this goes out of the window, but we're talking about peri-arrest. They're not dead yet, and you don't want to be responsible for causing the death. So what we have instituted in our emergency department as a quality improvement project is what's called the Airway Timeout. You can, if you guys need this, feel free to get my email from Dr. Banerjee. I can send this to you. But you want to put this on a little badge buddy or just kind of a fourth of a paper, 8x10 paper, so you can always have this out. It goes over things that has to happen and has to take place literally before every single intubation. And I'll tell you, some things on here seem silly, but every single thing that is on here has happened before in an intubation that I've been involved in and has led to a bad outcome or potential for a bad outcome. And when I say that, for example, on this first one, this one here, where it talks about IO, IV working, blood pressure obtained, pulse ox working, you're like, why put that on a checklist? Well, we've actually went to intubate a patient before and didn't have a blood pressure. You're never gonna do that again after this lecture, right? Because we talked about hypotension killing the patient. So I need to know that blood pressure. If it's low, put the ET tube down, back away before I get my conducted energy device that I'm gonna get now, and make sure we get that blood pressure and increase it with our fluids, our blood, our push those pressors. Make sure your pulse ox is working. How in the heck are you gonna be able to tell when you need to abort that procedure if you don't even know where your pulse ox is, if you don't know it's 86 or 66? So make sure that's working. IVIO, this is mostly for us in the hospital when we're dealing with paralytics, but we have everything, it's great, the patient's pre-oxygenated, and then the nurse is trying to push medicine and it's not working, and we're like, what's happening? They push more and the patient's still awake, and you're like, what's happening? So these are all things on this list that we've actually encountered that, again, could have led to bad outcomes or have. There's another section on there that tells you exactly how to pre-oxygenate in case you forget that, but I encourage all of the medical directors to have that in the protocol. Again, specifically for pediatrics, because we don't have to intubate pediatrics mostly. Resuscitating before intubating, if you forget this lecture, there's a nice summary there about what things you can do for the HOPS killers. All of the equipment, this is another big one that we included here because we've intubated sometimes, unfortunately, without an LMA, and that could have definitely saved us. Same thing with the bougie. If you're just, what I say is there's no difficult airway. I'm not treating one airway different from the next. I'm treating them all as difficult airways, and I'm preparing as if all of them will be a difficult airway. Medications, there's that half double, remembering to think about hyperkalemia for those of you all who are using RSI. Get your drips ready. Considerations, we're gonna abort before when we get to 90% and go ahead and bag the patient back up so we can have more time. A couple of other things about like not using a paralytic if they're obstructed. So these are all things that we're going through in our checklist before we're doing this. And then finally, post-intubation, we want to confirm by end title. Does not matter if they have breath sounds that are equal. Does not matter if they have no epigastric sounds. Does not matter if you saw it go in through the king vision. What matters in the court of law and standard of care is what that end title is. And then finally, getting your sedation started for those in the emergency department, your chest x-ray, and getting your vent settings. So that's all I have for you guys. If you're not pre-oxygenating, go back and take that procedure to your counties. And thank you guys for having me here. Any questions?